abilities and severe behavior abnormalities such as irritability, apraxia, and agnosia, and restlessness. Alzheimer's patients frequently have non-cognitive symptoms such as depression, apathy, and psychosis, with impair and their day-to-day activities. Enhancement and lifespan of human beings in developed and developing countries has resulted in proportional increases in rate number of patients suffering from senile dementia. Alzheimer's disease is said to be the leading cause of dementia in elderly individuals. Alzheimer's and Related Disorder Society of India, ARDSI, is a registered national non-profit voluntary organization engaged in the care, support, training, and research of dementia since its inception in 1992. Alzheimer's and Related Disorder Society of India, Mysuru chapter was established in 2012 to cater the need of Alzheimer's disease patients and their caregivers. Now I would welcome Now I request Dr. Hanumanta Joshi, President, ARDCI, Mysore chapter, for a welcome address. I welcome you, sir.
Thank you, Dr. Neetu, for the nice introduction. At least the people are aware we have gathered today for the webinar. What is Alzheimer's and what are the complications with that? To speak about it, we have a versatile speaker and an expert in the field. Dr. Chandrasekhar is here. Sir, first of all, a hearty welcome to you. And thanks to you from RCM Mysuru for accepting our invitation and sparing your very valuable and busy time. Especially, I understand 4 to 5 is your very busy time, but finally you have accepted. Thanks to you and a hearty welcome to you, sir. And I take this opportunity to welcome our big sister and our energy and supporter of all our endeavors, Mrs. Vidya Shanai Madam here. Madam is the General Secretary of RCA National Chapter. A hearty welcome to you, Madam. And it's nowadays it's very difficult to catch Madam because she's in one of the webinar, both in national and international. But finally, we could request her in a very short span of time. So, Madam accepted. Thank you, Madam, for your acceptance for our invitation. Thank you so much. And I also welcome all the dignitaries here. We have Mrs. Bala from Deccan, Hyderabad, and we also have our very dynamic coordinator, Gopal Krishnan, Major Gopal Krishnan. And there are so many people who have gathered here today, and I heartily welcome you all. And we are eagerly waiting to listen to Dr. Chandrasekhar. This webinar series is for 2 days. One is today, that is 13th. And tomorrow also we have a spectrum of speakers. We have Dr. Amit Dayas from Goa Medical College. And we also have Dr. Pratibha Pereira, who is doing excellent work in the field of Alzheimer's in Mysore, Sri Sam Jesus Hospital. So this is the 2 days webinar. And incidentally, this is World Alzheimer's Month. And I am hopeful that many people are organizing various activities on eve of World Alzheimer's Month to make an awareness regarding Alzheimer's. So with this, I welcome you all for this webinar. And I am hopeful, especially the students who have joined here, the pharmacy students, hope you will take a very good information and you will be able to siphon it to the other people. That's what the expectation is. So with this, I heartily welcome you all once again and thank you. Dr. Neetu, you have muted.
Sorry, sir. Thank you, sir. Now I would like to welcome Vidya Shanai, Secretary General, ARDCI National Office, for the inaugural address. We welcome you, ma'am.
Thank you, Dr. Neetu. Firstly, thank you, Dr. Joshi, for inviting me to inaugurate the series. I must say that the cause of dementia is very dear to my heart, passionate about it. And, a person like you who's so active in working towards the cause, it ignites the flame in others. And you don't really give a choice for somebody to say no. So one makes the time and attends it. So it's my privilege here. Also, it's my privilege to be with Dr. Chandrasekhar, whom I admire and respect. I look up to for his experience, his humility, And so there's never a no when it's a cause for dementia. So, at the inaugural, I mentioned that we all know that it is a kind of a type 3 diabetes where it's not officially named so, but it is as good as being called one, as some researchers do. We also know that every 3 seconds somebody is developing dementia. So it's a very serious problem. It's a dragon we have on hand, and we have to catch and tame the dragon. And that is why we've had last year the theme for ADI being Let's Talk Dementia. And we go further today, this year, by saying no dementia, no Alzheimer's. For me personally, it is very no Alzheimer's. That means from the KNOW, we remove the KW and make it no dementia, no Alzheimer's. World Health Organization, the numbers of people living with, and almost 80% of them will be living in low and middle income countries. It's a serious problem. And web series, like all our artsy chapters, are doing extremely well in their capacity, in their own way. And I think everybody is wanting to do something, and they are doing. So I'm very happy that Mysore chapter has come up with this series. It's very, very active. They have a macro picture where the activities are concerned. And of course, it's like all of us in the chapters are wetting stones to each other. Each of us is igniting the flame more and more to work towards a cause. So this kind of a series where we talk dementia, we spread the awareness of no dementia, no Alzheimer's is very important, because this is the way we are going to increase the awareness of the disease. We are advocating for it. And more importantly, this is going to lead to social stigma being reduced. India has that cultural problem where, social stigma makes people not admit that there's a member living with dementia in the home. And I think the awareness that we are spreading, that, dementia is a neurological disorder, just as somebody would have of another organ, like the heart, the lungs, kidney, which is now accepted. Even TB is now accepted. So why not dementia? Why should we isolate these people who have a member? Its etiology is not known. It could happen to anyone. So let us join hands. Let us spread the message and make people aware that it is any other health problem that we need to attend to. Earlier the better, and earlier the diagnosis we do, and intervention is done, whether it's pharmac intervention or non-pharmac intervention, we are actually leading them to a better quality of life and well-being. So with this, I wish you good luck for this series and maybe more coming up, and all the best in future. And Dr. Chandrasekhar, I'm all ears to listen to you. Thank you once again.
Thank you, ma'am. Thank you for your valuable words and time. Now, I invite Dr. Chandrasekhar, today's our chief guest and speaker for the special occasion. Dr. Chandrasekhar is the founder, director, and currently managing director, senior consultant in neuropsychiatry and geriatric psychiatry at Asha Hospital, Hyderabad. He did his post-graduation from National Institute of Mental Health and Neuroscience in Bangalore. After completing his training in psychiatry at NIMHANS, Bangalore, he has been the clinical practice for last 38 years. He has been associated with ATSI Hyderabad chapter for last 20 years. Presently, the Day Care Center for Dementia and Respite Care Center for Dementia at Hyderabad are functioning under his guidance. He is the pioneer in concept of delivery of mental health care in all dimensions in private sector, and has established the first corporate hospital in the area of mental health 2 decades ago. Presently, Asha Hospital in NABH accredited psychiatric hospital offering DNB course in psychiatry and PDF program in child psychiatry. He is the teacher of DNB psychiatry since 2006. His area of interest including neuropsychiatry, geriatric psychiatry, and mental health legislation. He has been guest faculty for various CMC programs at state, zonal, and national level conducted by Indian Psychiatric Society and Indian Association of Private Psychiatry. He is the past president of Indian Psychiatric Society, Andhra Pradesh chapter since 1989 to 1990, past president Indian Psychiatry Society South Zone, and presently vice president of AHC Hyderabad decade. He is also managing trustee of Chetana Medical and Educational Trust, which is associated with Institute for Rural Health Studies, run rural psychiatric services. Now I request Dr. Chandrasekhar to take over the session. I welcome you, sir.
Thank you. Let me share the screen. Are the slides visible?
Yes, sir.
Good evening to everyone. Dr. Joshi, Dr. Vijayashanai, and all the dignitaries and students. In the next 35 minutes, I would be probably focusing more on the management issues of dementia. After giving a brief introduction what dementia is about, my focus is going to be more on what exactly we mean by a collaborative care in dementia management, which I feel is absolutely necessary. When you really look at what dementia is all about, the portrait on the left side tells you in one go. He is William Molen. He is a German artist who could do his self-portrait in 1996, got affected by Alzheimer's, and within a span of 4 years, you could see how distorted his own image. He himself could not recognize his own image in the mirror. This is how devastating a process of dementia can occur. Dementia is basically, when you look at it, there is significant cognitive impairment, which occurs very gradually. So individual will not be able to focus his attention, will not be able to do the normal activities of daily life because he tends to forget how to go about doing things. He tends to forget how to organize his own day-to-day activities. His learning and memory are usually affected in the sense that new learning becomes very difficult. Though old memories still are retained to a large extent, it's difficult to focus the attention on new information and store that information, so they tend to forget, especially the recent events. For example, a person might talk to you at length about what he did in his school days, but ultimately not able to tell whom he met this morning or what he ate this afternoon lunch. So this sort of a recent memory impairment is one thing which we usually encounter in dementia. Along with that, you also tend to see language disturbances. People cannot get sometimes the appropriate word when they are speaking, so they tend to sometimes jumble the words or misplace the words or not get the word at all. Then their ability to navigate themselves in a given situation, it may be within the home, it may be within the locality, or where they have gone around for several years in their life, they tend to forget how to reach that place. And sometimes, or many a time, they also lose their social cognition. That means in terms of recognizing the people whom they knew for years. So these sort of cognitive deficits which occur very gradually over a length of time generally affect the individual's whole life. Not only his life, because of this, the lifestyle of his own family members also gets affected. So these cognitive deficits start interfering with independent functioning in their daily activities. This is in a nutshell what dementia is about. So approximately 10% of cases diagnosed with dementia have a reversible cause of etiology. See, dementia is a general term basically. It is like someone has got a fever. Fever can be because of, say, typhoid. Fever can be because of tuberculosis. Fever can be because of some viral infection, or fever can be because of several other reasons, as most of you know. So it's a general term basically. And if, see, dementia basically means global cognitive decline. So when I find global cognitive decline in an individual, probably there are 10% of the cases in which you find a cause for this dementia, a cause for this cognitive decline, which can be corrected sometimes 100%. For example, say there is a metabolic disturbance because of which you find the cognitive disturbances. There can be a thyroid disturbance, hypothyroidism, which can lead to cognitive disturbances. When you correct that, automatically the cognitive disturbances are corrected. Or vitamin B12 deficiency, where you supplement the adequate dose of vitamin B12, the process of cognitive decline stops or gets reversed. So there are about 10% of the cases whom we diagnose dementia wherein there is a treatable cause. Whereas there are several other neurodegenerative disorders which causes cognitive decline where you see dementia. Everyone who suffers from Alzheimer's disease has dementia, but not every dementia is Alzheimer's disease. This is one thing which I want you to keep in mind. So whenever someone says dementia, don't immediately jump to the conclusion that it is Alzheimer's disorder. So, but it is known that 70 to 75% of the dementias belong to the category of Alzheimer's. So that is the reason why Alzheimer's is very commonly seen and very commonly talked about. So what happens when the dementia sets in? When the dementia sets in, it goes through 3 different stages or gradual stages. The mild stage of dementia, which a person can probably be there in that stage up to from 2 to 4 years, where the predominant thing is loss of memory, language difficulties, mood swings, personality changes, diminished judgment and apathy. Various symptoms like these are seen over a gradual period of time, which starts deteriorating over a few months. So from this mild stage of dementia, the person progresses into slightly more severe condition, which is a moderate stage of dementia, where the person loses the ability to retain new information. Then there is vast changes. This is what we call as a behavioral and psychological symptoms in dementia, commonly abbreviated as BPSDs, wherein you find a lot of psychiatric problems in these moderate stages, where they don't sleep, they become irritable, they become aggressive sometimes, they keep wandering away from home, and there is a lot of memory loss. All these, and they require a lot of assistance in the moderate stages. In the severe stages, where you find there is gait and motor disturbances, the individual will not be able to walk properly, he becomes bedridden, he will not be able to take care of his toilet needs, he requires long-term care management, he requires total assistance, and this is what happens through the stages of dementia. Do remember that when you diagnose Alzheimer's disease, this person can live an average anywhere between 4 to 12 years or 13 years. Sometimes we have seen persons with some good care living even beyond 14 to 15 years. This happens with most of the dementias. Now, when you tend to see a case of dementia or know a case of dementia, what is the care pathway which you can think of? I have diagnosed dementia, but what is going to happen once the diagnosis is made? The care pathway in the dementia should go through 4 different stages or 4 different continuous sort of a care pathways. One is the early symptom identification. What happens is early symptom identification is usually by the caretakers, by the friends, the family members, in the community where he is living, and also to some extent occasionally by their family physicians. Because when we are interacting with a person on a day-to-day basis, suddenly you find this person forgetting things. For example, suddenly the daughter notices the mother has prepared, who was a very good cook, suddenly starts forgetting putting salt in the sambar. Or someone who is able to talk about various news items in the newspaper suddenly stops discussing about it. Or the person keeps on telling the same thing over and over again. Or sometimes he tends to keep searching for items like, say, spectacles, keys, or common things which he uses very often. So this sort of changes or this sort of a difficulties in remembering things, in doing things, which the family members notice, the friends notice, or sometimes even the colleagues, the workplace, the individual is still working. Often this is observed. And this is what we call as a early symptom identification. Then, so early warning signs of dementia has to be kept in mind, because diagnosing dementia, we have to see it sooner than later. So how do you, the top 10 warning signs as for the ADI, Alzheimer's Disease International, has put forward is top 10 signs. One is the recent memory loss affecting the individual, difficulty in performing the familiar tasks, the problems with language, disorientation to time or place, poor or decreased judgment, problems with abstract thinking, misplacing things, change in mood and behavior, change in personality, loss of initiative. All these things are the very early signs of Alzheimer's, and one has to be aware of this. One of the main purposes of the various activities of ERDSI is to increase awareness. Why are we increasing the awareness? Why are we trying to increase awareness in the community across different spectrum of the people? It's mainly to tell them that the families can recognize, the communities can recognize, everyone in a given community can recognize the earlier symptoms of dementia so that the help can be rendered soon. What is the rationale for this early diagnosis? The rationale for the early diagnosis is addressing safety issues to minimize hazards from driving, cooking, or sometimes over medication. Because if the individual starts having the dementia, then automatically, because of his loss of sense of direction, as I said, there are a lot of losing the direction in a familiar environment, losing the way, probably he may, or his reflexes can be a little bit slowed down. So the driving can be affected, it can be hazardous, or a housewife, when she's cooking in the kitchen, may forget switching on the gas, switching off the gas, or probably harm herself by touching something which is very hot, because being very forgetful. Or sometimes even anyone forgetting that they have taken their first dose of medicine in the morning, continue to repeat the same dose even when it was not required. So all these hazards can be prevented. So reduction of caregiver stress via early education about the disease, services available, and how to handle patients' needs. Often we find the families are really distraught. When someone in their family is suffering from dementia, they don't know what to do. Because they don't know that it is a disease process which is making the individual behave the way they are behaving. So they get angry, they get frustrated, they shout at the patients, they shout at the family members who are affected with dementia without knowing what is causing them to behave that way. So if they know that diagnosis is made, they can understand the process through which or the suffering through which this person with dementia is going through and probably be more helpful. And also they will understand how to handle the patient's needs. Then it is also known that specific treatments that are available work best when started early in the course of illness. That is the rationale for the early diagnosis. Now, the second step in the care pathway is the diagnosis. How does the diagnosis occur? When I suspect a dementia, I do have to consult a person who is equipped with the knowledge of the diagnosis of dementia. So consultation process is one thing we should set in next in the care pathway. So the consultation basically comprises of the various cognitive assessments and various memory tests which are conducted to determine the extent of the memory loss, the extent of the memory disturbances, the extent of various cognitive impairments which are present in that individual. Sometimes, if not every time, certain scans like MRI scan or a PET scan or a CT scan, all these things are ordered to confirm the diagnosis. So confirmation of the diagnosis through the consultation and testing process is the next step in the care pathway. So once the assessment and the diagnosis is made, the next step is the communication of this diagnosis. One of the major things which often is probably not done very efficiently in most of the situations is that once you diagnose a person is suffering with dementia, what often is told to the family is in a short sentence that your relative or your father or mother or grandmother or grandfather is suffering from dementia and this is our diagnosis and this is what you should do or what you should not do in a very cut fashion which is not going to help the individual. This diagnosis is made and the way it is communicated is a very essential step in the care pathway, which I think is the most significant thing, the most important thing in the communication. So you have to spend time. You have to spend time, you have to call the significant family members, you have to call the significant carers, you have to inquire who is going to be with the patient, then tell them about your diagnosis, how you are going to further help the family in the process of minimizing the difficulties which the patient is facing. So this communication, the third important step in the care pathway is communication, and this communication has to be done adequately. You may have to spend 1 or 2 sittings. In fact, generally what I tell most of my patients when they come once I make a diagnosis that I first call them, spend enough time with them, explaining to them what my diagnosis is, give them sufficient time to ask questions, give them sufficient time for them the information which you have given to sink in first. And then, because they have their own emotional things to handle, it is not that easy to accept that your father or mother, suddenly the doctor has diagnosed that he is suffering from dementia and you are at a loss. How can such an intelligent person who has taught you, has brought you up, suddenly develop this sort of a problem? So that is important thing. The ultimate thing is final step of the pathway, the post-diagnostics support. I have diagnosed, I have communicated, but what is the support which you are trying to give to this patient and the family? This is the next thing in the care pathway in the management of dementia. So the post-diagnostic support is, one can divide it into the pharmacological management. One thing is for cognitive decline, how much of cognitive decline I'll be able to handle or prevent. See, though you may not be able to reverse the cognitive decline in dementias, very often with the medications available right now, the common medications which are available right now, which are routinely used in majority of the clinics, is donepezil and also memantine. These are the two common drugs. Of course, there are plethora of other drugs which as pharmacology students most of you might be familiar with, starting from ginkgo biloba to various other herbal remedies and so many other things, even your curcumin. So many things are available to try. So the pharmacological complaints consists of drugs to prevent or to delay the cognitive decline. The second thing is you might also find symptoms, what we call as a behavioral and psychological symptoms of dementia, wherein depending upon the profile, depending upon the symptom profile, we might have to use an antipsychotic like a Risperdal or a olanzapine, or you might use an antidepressant like a escitalopram or sertraline, or you might need to use sometimes an anticonvulsant like valproate or a carbamazepine or oxcarbazepine. So for BPSD to control and also sometimes to help to improve the sleep, you may have to use, usually we try to use melatonin for sleep disturbances and generally go for non-benzodiazepine hypnotics like zolpidem. So this is how we go about doing the pharmacological management. Another important thing where again you have to keep in mind is about the comorbid diseases which occur. Majority of these people do have a comorbid hypertension or diabetes or sometimes COPD, chronic obstructive pulmonary airway disease, and so many other, it could be chronic kidney failure. So all these comorbid diseases have to be simultaneously be looked into, and the medications which they are getting needs also to be looked into. So this is in the post-diagnostic support, you have to evaluate the whole medical regimen on which the patient is on and try to advise the family adequately. What are the non-pharmacological intervention? If you look at the non-pharmacological intervention in the post-diagnostic sort of an interventions, one is targeting the carers. You are targeting the carers and targeting persons with dementia. Both you need to do. So how do you target the carers or the caregivers? So as I said, the caregivers do come up with several problems. They do come up with problems which they want to discuss. Sometimes discussing with each other, sometimes discussing with the doctors, sometimes discussing with other professionals who are involved with caring of the dementia. So the monthly theme-based group meeting. So sometimes we organize group meetings wherein a particular theme, like in a month it can be aggression, how to manage aggression. In another month it could be how to manage the sleep disturbances. In another session, it could be how to manage the feeding problems. So this sort of a group meetings or the carers meeting monthly or bi-monthly will always help the families to take care of their patients. Another important thing in the post-diagnostic help is the activity centers or the daycare centers where the individual's cognitive abilities can be sharpened to whatever extent possible. So in the case of dementia, sometimes there can be reasons why they become behaviorally disturbed because they are not put into any activity. So one of the things, the way we can reduce the restlessness, one of the ways where we can reduce their sort of a anxiety and worries and all these things, not only to the persons with dementia, but also to the family members, is engaging them in activity center. This is another way of doing things. These are all the various activities which the individuals can be engaged with. So, if you look at the totality of delivering a dementia care, you go through these. Once the person is there in front of you with dementia, imagine that even that how do I prevent this individual from getting affected with the various consequences of dementia. That means a person with dementia may injure himself, a person with dementia may not take care of his physical health, a person with dementia may have several other difficulties. How do I prevent those difficulties much beforehand? That is one way of looking at it. Then how do I diagnose his suffering much earlier? That means how well I diagnose various other conditions the individual is suffering from. Because sometimes the persons with dementia will not tell you that I'm having a tooth pain. Or the person will not tell that he has got a pain stomach because he hasn't passed stools for several days. So how well I diagnose it is an important thing. Then how well I support these individuals and how well I make these persons living much more worth or much more happy, and how much dignity I can give these individuals when they are about to die. So this is what the whole planning of dementia care management is important. So coming to the issue of what is this collaborative care. As I always emphasize, dementia care is not a clinic-based or hospital-based process. It has to occur in a community, in a primary care setting. And collaborative care, the primary care framework will give desired results. And this approach can reduce burden on the healthcare system, caregivers, and persons with dementia. So training the primary care physician in early diagnosis, appropriate referral to the specialist for confirmation of diagnosis, and communicating and indulging in sensitive discussions are part of the care program. What I feel strongly about engaging the primary care physician is, suppose the patient comes to you, first thing we can inquire is who is his family physician, or where does the family go when they have a problem, health problem with any of the family members. So someone can be a family doctor, it can be a family physician, or it can be anyone. Any doctor who is closely associated with that family to whom they go for any health need. Take this person into confidence as far as the patient's needs are concerned. Once I diagnose dementia, I would preferably engage a partnership with the primary physician, primary care physician, or whoever the doctor who is treating this patient. So this is where we have to have the first collaboration. The first collaborator is the family who is or the carer. The second collaborator is the family physician. Then this family physician has to also understand that this individual with dementia might need the care of a occupational therapist, maybe care of a speech therapist, may need the care of a psychiatrist, may need the care of a neurophysician. So he has to be aware of the role of different specialists at different points of time in the evolution and course of the dementia. So this sort of a liaison and collaboration is an essential component in the care of dementia. Training and support allows the primary care doctor to be an anchor for treatment and a familiar, trustworthy figure to the person with dementia and their family. So suddenly the person with dementia has got some problem. Whom do they go? So they go to the person who is the primary care physician who can direct them to the appropriate care. That these people trying to contact the appropriate specialist where it may go wrong. Suddenly the person may come to me thinking that the behavior is because of a psychiatric issue. Suddenly I recognize, no, it's because of a neurological issue. So instead of all this, if there is an anchor who is a primary care physician, who can collaborate, then the process becomes much simpler. So managing the person's dementia is not in the domain of any single specialist, and a multidisciplinary team is required, whose advice and expertise needs to be coordinated and implemented by the primary care physician. If we can achieve that, see, in every community where we diagnose dementia and where someone is taking care of them, if this sort of a arrangement can be sorted out, then dementia care will be much, much better. So the process of holistic caring occurs. The person or carer suspects dementia and present to the primary care physician. So our education should be initially to the primary care physicians, the family physicians, sensitizing them to the diagnosis and identification of the dementia. So once he himself suspects dementia, he can order some basic dementia investigations. And with some probability of dementia in mind, then can refer to a specialist for confirmation. Once the confirmation is there, the confirmation, diagnosis, and communication, which I already told you earlier, has to occur. And in the locality, if there is a referral or an organization or some center which is more specialized in dementia care, it can be referred there. So this process of holistic caring is essential in the management of dementia. So what does this dementia care center has to liaise with? So the dementia care center, you can call it trust, you can call it RTSI, you can call it by any name. But ultimately, this center is interested in providing care for people, persons with dementia. So these people should liaise with a memory clinic for early diagnosis. Also see whether they can liaise for a home care wherever it is required, and also see whether this center can liaise with an activity center which enhances the cognitive abilities of the persons with dementia, and also look into the establishment of respite care and long-term stay. There will be a stage in the process of evaluation of dementia where the family members do need some respite. It may be 2 months, 3 months, 6 months, who knows? They might want to take a break. So you need a center where these people can be taken care of. Then of course, the end of life care or the palliative care, end of life care is another eventuality which these people have to be offered. So ultimately, if you are trying to project the care of dementia, it has to have a holistic concept. It cannot be that I have diagnosed dementia, it is a headache, the family members to go wherever they want to get the help. If we are organizing dementia care services, it should have all these facilities, and anything which you cannot provide any of these things, then your care or the management is incomplete. So what are the challenges? So once we want to put this sort of a model into practice, what are the challenges which we come across? Without financial incentives, any program is unlikely to succeed. Hence, funding for collaborative care models should be adequate. So if there is a dementia care trust, there should be enough funds created for this purpose so that they can integrate these services adequately. When you look at the various dementia care programs, they are very sparse in isolated pockets of the country, and probably they lack adequate professional and financial support too. Research in dementia is again limited to certain very large institutions and poorly shared with the service providers. Ultimately, unless that research which is done in your center, in any place, unless it is shared with the service providers, it has got no meaning. So this is where again sometimes there is a lacuna. So the continuity of care is needed, as I said, diagnosis, home visits, home care, activity centers, respite and long-term stay centers, all these things are required. Often dementia is stereotyped, calling it as a burdensome, it's a hopeless, it's not worth the time and energy. All these things, in my opinion, can be negated. One need not be so desperate. Persons with dementia can enjoy their lifespan, whatever it is they are left with, and still make little bit of comfortable living, make life comfortable not only to them, but also to the carers. So So it is not that burdensome, it is not that hopeless, it is not that we are wasting our energies on them. So in conclusion, we are going to witness a surge in case of dementia in the coming years. There is no doubt about it. I didn't go into the statistics. Currently, the available services are sparse, and we have to prepare ourselves to meet the future challenges. We require models of care which are practical and sustainable. You may come up with a care model which is very good, excellent, but unless it is sustainable, it should not be, model should not be there. If this individual is present, then only this model can work. No, it has to be universally be applicable. The model which you create should be universally be applicable so that it can sustain by itself, not only in terms of economically, but also in terms of the way the care is taken care of. We need skilled staff. We need to train staff to handle these people. So we need partnership with carers, the family members. We need more facilities for assessment. We need to engage people for early identification and post-diagnostic support, and a person-centered, individualized care plan executed by integrated care teams in dementia-friendly communities, environment, wherein you involve the persons, involve the families, which is the need of the hour. And I think organizations like ARDSI have to be instrumental in these processes. Thank you very much. Once again, I thank Dr. Joshi for giving me this opportunity to share this. Thank you.
Dr. Neetu, you have muted again.
Sorry, sir. So thank you for your informative session, sir. So we have one question from delegate, Mr. Govinath Khanna. He asked to highlight the dosage forms and also IR and ER in managing dementia.
What is that other one? Other half?
First, highlight the dosage forms and IR and
medications.
Yes, sir.
See, I didn't specifically go into detail because I didn't want to make it too pharmacological oriented thing. But anyway, see, usually the donepezil dose is starting dose is 5 milligrams, and usually we increase to 10 milligrams. Though there are sustained release preparations of 23 milligrams. So that is donepezil dose. Generally, 10 milligrams is an adequate dose in majority of the cases. Memantine can be anywhere between 10 to 20 milligrams. Donepezil is available as extended release forms mainly. A lot of times we have a combination of memantine with donepezil, very often marketed in combinations. The other ER forms which we generally use with reference to dementia is only the psychotropic drugs. When you have valproate, which we use in say sustained release forms. In practice, I didn't find much of a difference as far as the immediate release or extended release forms of donepezil, frankly speaking, because the half-life of most of these drugs are 24 hours, so that hardly makes a difference in my opinion. That is about the dosages. Otherwise, there is nothing more to that. Yeah.
Thank you, sir. So one more question from one delegate. Relationship between OCD and dementia.
See, OCD, sometimes in the earlier onset of dementia, in the early phases, sometimes you can confuse it as OCD because the individual, because he forgets, keeps checking repeatedly. A lot of times we do get the patients who report this, wherein the family confuse it as a repetitive behavior. The individual forgets that he has locked the door and he keeps checking it again and again. There is a difference between OCD and there is a difference between forgetting and checking. So this confusion occurs in the early stages of dementia in some individuals. In OCD, the main symptom is you are not satisfied that you have performed the act sufficiently well. Whereas in dementia, you repeat the act because you have forgotten that you have done it before. This is the fundamental difference. So, usually, as a differential diagnosis, it is important in the early stages of dementia. Otherwise, it is not OCD as a part of dementia is not that commonly observed.
Thank you, sir.
We have with us Nilanjana Malik, madam. Madam, would you like to add some words here?
Thank you, Dr. Joshi. Thank you, Dr. Chandrasekhar. I am sorry I got in late, but it was really, really nice to see and hear you. I haven't heard you before, so I wanted to hear. The management is so important, and if it comes from doctors like you, I think it is so very important. I think people need to hear more and more from physicians as to how management of dementia, all aspects, the holistic care part, because we keep, fighting between the medical culture and the holistic care part. And I think, seeing the person and then the disease, I think there's a tug of war, especially the healthcare practitioners, they kind of have difficulty in whether they will, see the dementia first or the person first. But I think if we work as a team, just the way you explained, as a team, then I think every person can, highlight the importance of each aspect. So wonderful. I really enjoyed your talk. Thank you so much. Thank you.
Thank you, ma'am, for your time. So we have one more question from Asina. She's 65-year-old. So can you please suggest any precaution to not to get dementia?
The only precaution as such is keep yourself as active as possible. Keep doing some puzzles, keep reading. I don't know your profession, but for a professional, try to keep in touch with the profession which you are practicing for all these years before. And keep yourself active both physically and mentally. That is the only way where we can prevent. And especially a healthy diet with vitamins is important. Balanced nutrition. These are all the things which are general preventive measures, trying to see that your immune system is good. And these are the things. Apart from that, the mental activities. Try to learn anything new also even at this stage. So these are the things which keeps the dementia a little bit, if at all, if it is going to affect us, it is going to be a little bit delayed. So that is the only way to prevent.
Thank you, sir.
I think Professor Chandran wants to ask a question. Chandran, sir. Please unmute yourself.
Now, can you hear me? This is myself, Professor Chandran. I'm very happy to have this session. It was very informative section because this since about 30-40 years ago I read about this dementia, Alzheimer's disease. Am I audible to everybody?
Yes, yes.
Hello. Am I audible?
Yeah.
Yes, sir.
Okay. This dementia, Alzheimer's disease is due to the formation of the free radicals in the body. So we used to do some antioxidants. Some of the participants asking about how to prevent this. Usage of antioxidants like vitamin C, vitamin E, vitamin K in small quantities. And also trace elements and trace minerals like selenium, copper. These are all some of the elements which we are using in a little quantity day by day. So it is scavenging of free radicals, which will help us to postpone rather to avoid to get this condition. This is not a disease, something which is age-related phenomenon. So you can manage. This is my experience, my opinion. I just want to share my information to the audience with the permission of our beloved speaker, Dr. Chandrasekhar. Hmm? So dementia is something which you have to give a sort of moral support and a sort of teamwork to help the patient to come out of these conditions and make them active, make them happy. This is my experience. It's not a question, something anyone asked you because you are given everything excellent. Thank you very much, Dr. K. Chandrasekhar, sir. And thank you very much, Dr. Hanumandaja Joshi, for giving me the opportunity to share my experience.
Thank you very much.
Thank you, sir.
So are there any other questions? No.
Hi, Dr. Chandrasekhar, sir.
Yeah.
This is Srinivas from USA.
Yeah.
I have one probably a silly question. Now, this question is, for example, if my mom has dementia, am I expected to see dementia or not? Or any experimental evidence is saying, yes, the children will have, and probably not. Or is there anything that you can say it for sure? That's question number one. Question number two.
Yeah.
Can I please continue question number two?
Sure, sure.
Yeah. Question number two is like, is that dementia is that dementia is pretty much like in the written that you're gonna have it pretty much like since your birth, is something that is unavoidable for a person? Or can you just say like you can do something to completely avoid it? Like it's not about getting later or getting earlier. Like, can I completely avoid not getting dementia at all in my lifetime?
Yeah. See, there are two. I mean, the first question is the genetic possibility or the transmission in the family. It is only about say 2 to 5% of the dementias are genetically transmissible. Rest of them are non-genetic. So, and as I again said, dementia is a global term. So it depends on the type of dementia, it depends upon the various other neurodegenerative disorders because of which the dementia is occurring. So that is one way of looking at it. So there are some ApoE testing and all those things, but right now it is not done as a routine in most of the things. I think still research has to go on, because I think some of these preventive things or the genetic testing is also a little bit tricky in my opinion. Suppose if I don't have any definite way of preventing or giving a cure or something to that management, it is just I'm increasing the anxiety. Suppose if someone diagnoses that at the age of 40 years, that I may get dementia at the age of 65 years, and there is no way of stopping it, what am I going to do? Worrying for the next 15, 20 years.
Yeah, just freak out.
It's a dicey thing sometimes, even these genetic things. So I think we have few more probably decades to understand it fully. Second question was about is
it kind of written on my fate that I'm going to get it, or since I was born?
No,
or can I just
no, there's nothing like that. See,
okay.
As I earlier mentioned, the only way of trying to see that our brain doesn't deteriorate fast is to keep it active as much as possible. That is the only way. So there is nothing
because
like that.
The question I has, even people with the active thinking and active brain functionality, like a Atalbi or Vajpayee, got a dementia. So I don't understand what's the reason behind it.
No, that's what I'm saying. See, the reason is still, very difficult to pinpoint as such in most of the instances. See, Alzheimer's, as of today, there are several hypotheses. The research this is deposit of basically amyloid into where there is a neuronal degeneration. Basically, there is a degeneration of the nervous system. Basically, the cells are losing their architecture. The cerebral architecture is lost. So the functioning of the brain is almost lost. So how it occurs, why it occurs is still a point of research. At this juncture, it cannot be translated much into the clinical domain.
Okay. So the way I see it, even we do the best we can, being active physically and mentally, we
Still
could
there
get
is
it.
a
Just
chance. There is
okay,
a chance.
good.
Yeah.
That's all I need to know. Okay, thank you. Thank you, Dr. Chandrasekhar,
Right.
sir.
Right. Thank you.
Sir, I'm Indudar calling from Shimoga. I have a question. Is there any remedy available with the alternative system of medicine, say from phytochemistry, or ginseng and ashwagandha? Whether will it?
No, this is what I was telling. There are several other remedies which are being tried, starting from curcumin, ashwagandha, ginkgo biloba, and people are coming up with different say remedies for this. I think still I don't think last word is still said.
Okay.
But ultimate, my opinion is whichever is useful is always can be tried. If there is, as long as there is no harm and there are no side effects, whether it's a herbal remedy, whether it is homeopathy, allopathy, or whatever pathy we call it, I think if it is going to help the patient, it is welcome.
Thank you, sir.
Yeah, I think there is a question from Mr. Gopinath Karanam. He is a pharmacist, senior pharmacist in Tirupati. Does doxycycline have any role in dementia besides antibiotics?
I haven't specifically heard about doxycycline as such, though people have tried various antiviral things, people have tried anti-inflammatory drugs. But doxycycline specifically, I didn't come across, frankly speaking. I'm not sure, I have to check.
I think that's it, Neetu.
Yes, sir.
Only these questions we have. Yeah.
Yes, sir.
So should we conclude it now? So thank you very much, Dr. Chandrasekhar, for the wonderful talk. And yeah, there is a message from Gopinath Karanam. Why don't you ask the question directly, Gopinath sir? Please ask the question directly. Okay. Oh, fine. So with this, we have come to the end of today's webinar. And first of all, we highly thank Dr. Chandrasekhar for the wonderful talk. He added some more information, which is very much informative. And especially we like the last slide, the challenges for, the RC chapters. How do we proceed and how do we be able to help the people? It's a really an eye opener, sir. And we need your suggestions and guidance in future also. We'll be definitely troubling in future. And before we end, let me inform, there is one more webinar tomorrow in which two speakers will be speaking. One is Dr. Amit Dayas, who is a well-known physician working in the area. And we also have Dr. Pratibha Parera, kindly join us. And Chandrasekhar sir, thank you very much for your excellent talk and all the patience and spending a lot of time with us. Thank you very much. And thanks to Vidya Shanai madam also. I think she has to catch one more webinar, international webinar. And Nilanjana madam joining us, all the way from West Bengal. And Gopalji. And now I can see Sonika madam also from Haryana. So thanks to everyone for your kind participation and appreciation to our anchorer, Dr. Neetu also. Thank you for nice anchoring in the last moment. And thank you so much. Please join with us to make an awareness regarding Alzheimer's. Thank you so much.
Thank you, sir. Thank you. Thank you, sir, for organizing such a wonderful webinar. Thank you so much, sir. And I express my sincere thanks to all participants, and I hope all of you will join for tomorrow's webinar also. Thank you all. Have a good day.